All right, so today for my OSCE, I'm going to be doing a respiratory assessment. So I'm going to want to perform hand hygiene. I'm going to want to go in and introduce myself to my patient. Hi, my name is Connie. I'm going to be your student practical nurse today. I'm going to be doing a respiratory assessment, which is going to involve me looking at, feeling, and listening to your chest on the front and back side. Is that okay with you? My patient's going to say yes, that's okay. And so I'm going to go ahead and start my respiratory assessment. So I know when I'm doing an assessment, I want to first inspect. So I'm looking at my patient and I'm looking at first their face for any signs of cyanosis, nasal flaring, or open mouth breathing that could indicate that maybe they're having some difficulties breathing. I'm also going to look at the neck and throat for any indrawing, which could also be a sign that they're having the difficulty breathing. Their body posture can also be an indication if they're tripoding or leaning forward, or if there's any indrawing or sucking in the intercostal spaces on the chest. So I'm inspecting and looking for that with my patient. I want to get a rate, a respiratory rate. So what I could do is place my hand on the chest to feel for rise and fall, or just look for rise and fall. And I want to count that for 30 seconds and then multiply it by 2. Okay, so I got 6 in 30 seconds. So I would times that by 2, being 12 breaths per minute, which is within the normal parameters of 12 to 20 breaths per minute. I want to talk about the rhythm next. The rhythm was a regular rhythm with a nice even tempo, equal in duration for inspiration and expiration. I want to talk about the quality of the breath. So the patient is taking nice deep breaths. They're not shallow breaths and they're not gasping breaths. And I want to talk about the effort. They're easy. The patient doesn't seem to be putting in any accessory muscle use or showing any signs that they are having difficulties breathing. So the effort is an easy and natural automatic effort to those breaths. So as I'm looking at the chest, I'm looking for the intercostal spaces if I can see them. If not, I can feel them. I'm looking that they're downward sloping and that the chest has a nice elliptical shape, or the thorax has a nice elliptical shape. I want to listen on the anterior chest and then the posterior chest. And so the first thing I want to do is kind of explain where the lung fields are and explain what I'm going to be listening for and where. So the way that lungs sit in the chest, I know that on the left-hand side, the upper lobe comes all the way down to the 6th rib. And then the 6th rib, kind of off to this side, is going to be the lower lobe. On the patient's left-hand side, or right-hand side, sorry, it's going to be upper lobe for the first 3 intercostal spaces is going to be upper. The 4th and 5th, there's going to be a slice out that's going to be our middle lobe. And then the 6th rib space is going to be the lower lobe. When I'm listening out to the sides, I'm going to be hearing vesicular sounds. And when I'm listening in the center part, I'm going to be hearing bronchovesicular sounds. When I place my stethoscope, I'm going to listen for a full inspiration and a full expiration. And I'm going to be assessing for any adventitious sounds. So I'm going to do that right now. So Mr. Smith, I'm going to be listening to your chest. I'm going to have you breathe in and out. If at any point in time you feel dizzy, please let me know. And I'll report my findings when I'm done. You can listen above the clavicle, but on him it's hard to get it flat. So I'm going to come to that first rib space. Second, third. I'm going to come down to the fourth so that I hit the mid lobe on this side. And the fourth, I'm still hitting the upper lobe. Fifth, sixth, I'm going to be getting the lower lobe. So on the anterior chest, I was hearing clear air entry to all the lobes of the lungs, so the upper, middle, and lower lobes. I don't hear any crackles, any wheezes, any adventitious sounds. It's a nice clear air entry and exit, so I can hear that nice clear expiration as well. I'm gonna go around to the back side of my patient now, and I'm gonna assess the posterior chest. So when I'm looking at the back, I'm looking that the scapula are nice and off to each hemisphere. So I know I have a scapula right here. I'm looking that that spine runs nice and midline. And I know that my lungs are going to be contained within the thoracic cavity. On the back side, I'm recognizing that the way the lungs sit in the chest and the way their lobes are, those upper lobes are just kind of at the top here. So that's going to be the upper lobes of the lungs. And then everything else is going to be lower, except for on that right-hand side. If I come over, but I would have to come quite far over. So in front of the mid-axilla line to hit that middle lobe. So it's not back in here, it's up in here. So I'm going to go ahead and I'm going to auscultate 8 anterior, posterior sounds. Again, I'm listening for full inspiration, full expiration, and I'm looking for any adventitious sounds. I also want to check for equal bilateral chest expansion. So I can count my vertebrae and come down. I can't feel Sam's vertebrae, but I would want to come down to like T8 or T9. And I want to pinch. And then as he inhales, I want to see if my thumbs come out evenly. So it should come out and go back. And that would show that there's bilateral chest expansion. So I'm going to listen now, and then I'll report my findings. So as I was listening, I was able to hear clear air entry and clear expiration with no wheezing, no crackles, and no adventitious sounds noted. Again, on my first 2 sites, I was listening in the upper lobes of the lung. Everything else was lower lobes of the lung on the posterior side. I want to come back and ask my patient their health history question. So, Mr. Johnson, do you have a cough? No? Okay. I could ask if he smokes, if he has any lung conditions, if he has any past surgical history with lung things. Lots of different questions that I could ask. That concludes my respiratory assessment, OSCE.